Hello, everyone. This is Kyle Blaylock. Today, I'm going to be presenting on a very interesting drug interaction between metoclopramide, which is the generic name for Reglan, and bupropion, which is the generic name for Wellbutrin or Zyban. Um, and we're going to discuss the interaction, why it's special, in my opinion, and then how we can apply the lessons learned from this drug interaction to your practice, and not just your practice, but also your research and even in your approach, as we will learn in the club and in your pharmacy endeavors. A lot of your success with research thrives from your approach and how you apply the principles of the scientific method to how you how you find your information for your research and how you write even your manuscript. All of it is connected, and we will learn today. So let's begin. So we have a case of a 28-year-old female. We're going to call her GA. She's presenting to the pharmacy with a prescription from Taylor Hospital. She was just discharged and she wants to get home as soon as possible. And the prescription says the following: metoclopramide 10 milligrams for 12 tablets, and the directions state to take one tablet by mouth 4 times daily as needed for nausea and vomiting. She states that she has significant nausea and vomiting, which is why she was admitted to the hospital. Her other medications include bupropion 300 milligrams and an oral contraceptive. So the pharmacist, you input the medication, metoclopramide, into the computer, and you get a warning on the computer. It just says that there's a drug interaction. Doesn't really say the intricacies of the drug interaction. I mean, the computer will tell you every possible drug interaction that comes up. A lot of drug interactions are not significant. A lot of patients are on multiple medications which overlap or have, duplicate therapy, and they are okay with them. So you don't think much about it. You're not really aware of any significant drug interaction, especially for like a short course of therapy. But it's a slow day today, so you say, I'm going to investigate this. You're not wary, but you decide you're going to spend extra time on this, and you're going to investigate it and figure out why there's a drug interaction. So you go on Medscape first. Again, the computer just tells you that there's an interaction, doesn't really tell you the details, so you're trying to figure out what the interaction is. And Medscape, which is a pretty reliable source, says there's no interactions. Like, okay. The next source you go is WebMD. So WebMD is not your first choice of websites to use, but it's still quite reputable. A lot of doctors will access this sometimes for basic information. And they have a drug interaction checker, which is somewhat reliable, and there's no interaction again. Okay. So then you go on to Drug Bank. This is now your third source you're checking. Drug Bank is also very reliable. It goes over things like pharmacokinetics, pharmacodynamics, receptors, and drug interactions. And it says here that, there is a moderate drug interaction. It says that combining metoclopramide and bupropion increases the risk of sedation, makes you tired. Well, if someone's got nausea and vomiting and they're really sick, I think the last thing you're worried about is them being tired. So you're not really that worried about that. And finally, you go into a Temple School of Pharmacy favorite. You go on Lexicomp, you type in metoclopramide, and you scroll down to the drug interaction section, and I don't see any bupropion here. It's not even listed. So there's really nothing wrong with this interaction, just some sedation and tiredness. So after consulting 4 reliable references, you decide to verify the prescription. You investigate a total of 4 sources, which is much more than you normally do. Usually you either go off your clinical knowledge or you check 1 source and that's it. You checked 4 and they all say it's okay. You just counsel GA that she should avoid taking driving while on this, and she should minimize alcohol, and it can cause tiredness. She thanks you, and you follow the script, and she goes about her day. So we did mention at the beginning, this interaction is special. Here's what we missed. Number 1, metoclopramide shows up as a category D interaction under bupropion. We checked metoclopramide, but we did not check bupropion. And it shows up here that bupropion is a strong CYP2D6 inhibitor, and it will significantly elevate levels of metoclopramide. It is actually not recommended. However, if you have to use it, up to 30 milligrams per day. GA script was for 40 milligrams per day. And again, risk D means consider modification, meaning it's really not preferred to use this. If you absolutely have to, monitor very closely, but it's really preferred to do something else. And a common example of category D interaction is benzodiazepine and opioids. You may see a lot of patients that are on both, but it's really not preferred to be on both unless there's no other alternative. Now we're going to go on to Lexicomp, the drug interaction checker on Lexicomp. And again, it is the category D, which again says consider therapy modification. And you should avoid category D interactions unless no other alternatives exist. Drugs.com is another reliable source, and this is showing as a major drug interaction. It can increase the risk of seizures. Okay, it can elevate levels of metoclopramide. And so the question is, why do the other sites pick up this drug interaction? If you go onto the Reglan label, the metoclopramide FDA label, some of the key drug interactions that are listed on the first page of the label includes bupropion and other strong CYP2D6 inhibitors. So the label even says it's a key drug interaction. Okay. Now, if we go on to the bupropion or the Wellbutrin FDA label, it says that drugs which are metabolized by CYP2D6, like metoclopramide, can experience significantly elevated levels. Bupropion is a strong CYP2D6 inhibitor. So metoclopramide and drugs like it experience an area under the curve, which increased 5-fold, and blood levels and half-life nearly doubled. So concomitant use of Wellbutrin with other drugs metabolized by 2D6 have not been formally studied. So we're going to see significant elevations in metoclopramide blood levels. Number 6, WebMD, the same exact website that told you that there's no drug interactions on a different page is now telling you it's a serious interaction and it can cause harmful effects. Number 7, PDR, which is Physician's Desk Reference, recognizes the interaction as major. See, a lot of other interactions are like minor or moderate, and here metoclopramide is listed as a major drug interaction. We see an increased risk of extrapyramidal side effects, so twitching and dystonia can happen with this. In addition to serotonin syndrome possibly as well. And it recommends avoidance of combining them two together altogether. If you absolutely have to give them together, maximum of 30 milligrams per day, but even that is risky. Number 8 is EPHA.health, which is a German resource. It kind of is like drug bank. Says that when you combine bupropion and metoclopramide, it elevates the metoclopramide levels by 218%. So it more than doubles the levels of metoclopramide. And then number 9, the Pharmacy Times, which is also a reputable source. I'm not sure if it's like a top tier source as far as like drug information goes, but it's still a reputable reference for providers and pharmacists alike. It says that you should avoid bupropion and metoclopramide because of various side effects, because of the risk. And the article was titled Metoclopramide and Dyskinesia. So again, the risk of extrapyramidal side effects. And so some of the serious side effects of metoclopramide, we have serotonin syndrome, especially if combined with other serotonergic agents. This woman actually was on bupropion as well. It was listed below in the article, but I wasn't going to show that. And then metoclopramide has been associated with dystonia, even with a short duration of therapy. There's even a black box warning for tardive dyskinesia and other movement disorders associated with metoclopramide. So this is a very real and very plausible effect of metoclopramide. It's not one of those really rare side effects. If you're not careful, it can happen. So how was this missed? This is a pretty significant drug interaction. This was prescribed by a licensed physician and approved by at least one pharmacist at Taylor Hospital. And the hospital staff also knew her home medications. She said that she went over her home medications. They missed this dangerous drug interaction. If you work in the hospital, you may notice that metoclopramide is falling out of favor because of these side effects. You might see things like trimethylbenzamide, which is Tygan, ondansetron or Zofran, prochlorperazine, among others. But metoclopramide is still being used sometimes, and it has some very real and serious side effects to be concerned about. This is based on a real patient who came to our pharmacy. So she came to our pharmacy a couple months ago, and we told her about the possible side effects. We warned her to take no more than 3 tablets per day, so 30 milligrams per day. I told her to only use it when she absolutely needs to. I said it's only for 3 days, so I think the risk is not extremely high, not very high, but there is still a risk, and to be aware of the side effects. And if she experiences any side effects at all, to stop using it and call her doctor right away, like a twitching or hyperthermia, signs of serotonin syndrome, or any kind of movement disorders. And again, the reason why it's special is because 3 reputable sources missed the drug interaction entirely. And even though the drugs are listed as key interactions on both of the FDA labels. So lessons learned. Remember that every computer program, every resource, every website is written by humans. And humans make mistakes. I cannot emphasize this enough. I have on multiple occasions caught mistakes on Lexicomp before. Small things, but still mistakes. I've caught mistakes on there and other sources. So realize that everywhere you look, there can be errors present. Always check multiple sources and always double check others' work, including other pharmacists. Just because a pharmacist verifies it doesn't mean that you shouldn't verify it also, okay? And again, always check multiple sources if you're not sure, and do not rely on just one source, and be wary of quote unquote drug interaction checkers. They can sometimes miss drug interactions, or they can tell you that there's interaction when really there is not. I remember one time I was on Pepsid and it said I had a significant interaction with one of my other meds, and on the label I went on Lexicomp and nothing was there. So they're not always reliable, and be cautious with them. Always check for CYP enzyme interactions. Bupropion was not listed in the metoclopramide monograph in Lexicomp, but it did say that CYP26 inhibitors. So if we go back here, it says CYP26 inhibitors. It is listed here. So it just lumped all of them together. But if you did not know that Wellbutrin was CYP2D6, you would not have had known that. Let's go back. Okay. And lastly, you want to use your clinical judgment to determine what is okay and what is not okay. You want to look at the patient in front of you. Remember, we treat patients. We don't treat lab values. We don't treat drug interactions. We treat patients. You want to look at all the risks and the benefits, consult multiple sources, utilize your clinical knowledge and your clinical experience. If you have to call the doctor, and then finally take all of it together and make the decision that you think is best. Just make sure your decision is well thought out and rational, and document everything. Document. There may not always be a right answer, but there definitely are wrong answers. Okay, now this can also apply to research, right? Humans can make mistakes, as we said before. It also includes mistakes in research and in a medical rating. Just because an article is peer-reviewed and published does not make it error-free, right? There will always be some kind of bias in every study, whether it be a review or any kind of other study. You want to try to avoid drawing concrete conclusions in your research unless it's already globally accepted, like it's something that pretty much everyone has accepted as being mostly or entirely true. For example, alcohol abuse can lead to cirrhosis. This is something that I think nobody would dispute. There is just so much surrounding evidence suggesting that alcoholism does lead to cirrhosis that most practitioners nowadays will accept that it is a common cause of cirrhosis. Just because 1 or 2 studies say something is true or false, or it's effective or ineffective for a certain condition, does not mean you should automatically accept that as true. I mean, what if you came across 2 studies which said that, and then nothing else in the literature said that? right? You might just say, oh, well, these two studies say X, Y, and Z, therefore it's true. But then if you did a little bit more digging, you would find even more, which would go against that. So always try and do a deeper search, but cautiously. And we'll explain it in the next slide. And finally, evidence-based medicine is just that. It is evidence-based. Evidence is the key word. We cannot prove anything, but we have evidence which suggests that it is effective for most or some people, but not all people, right? If we have a drug in the market, not everyone's going to benefit from it. Like Tylenol is a drug that everyone should know for pain, but some patients don't get benefit from it, and some patients actually get harmed from it. There actually have been documents of anaphylactic reaction to even normal doses of Tylenol. And then, of course, there are concerns about, like, if you take too much of it, of course, liver necrosis. So there's always risks, and not everyone benefits from every drug, but you want to look at the benefits and the risks. And in your approach, you want to remain skeptical of everything you read, but in moderation. There's nothing wrong with researching further and questioning things, especially if there's not been researched much, right? However, be aware that if you look long enough, you may find things which go against your other findings, right? So I would advise against going searching for articles which go against near unanimously agreed upon topics. So for example, going back to what we said before about the alcoholism and cirrhosis, if you try and search for an article which states that alcoholism really does not cause cirrhosis, I think honestly it'd be a little crazy. First, because it's well established, and second, because you may not find anything. And if you do, it'd be like the one paper that's like, 10 patients, and they're like, oh, well, we've concluded that alcoholism does not cause cirrhosis, right? And then what I have here is like trying to find an article which states ibuprofen is ineffective for pain when the drug has been around for decades, right? And it's already been approved and prescribed for pain for years, right? You may find something somewhere, but why would you want to look for that? Why would you want to even try to go against something which is so broadly accepted? This is where your clinical knowledge comes into play, right? If you know nothing about drugs, then yeah, maybe you would try and find something. But because we know in pharmacy school about ibuprofen, right, you would not want to do that. So use your knowledge as a backbone, and then branch off of that to search further. Okay. And again, you want to take all the information you find, look at the whole picture, right? Some articles might say one thing, others might say another, but maybe 7 say yes and 3 say no. There's more evidence saying yes than no. So maybe you would favor more strongly toward it being a yes kind of answer. Okay. And then finally, your final answer will derive from the number of sources which draw a certain conclusion. So like 7 versus 3, right? If they use any statistics, the strengths of the study. So if you have a study with 10 people versus 1,000 people, obviously the one with 1,000 people is stronger, right? Your clinical understanding of the topic and your clinical background is very important because it helps drive where you search and how you understand the topic. And then, of course, other variables which affect the outcomes. So this all started with a patient who was prescribed a drug, Metoclopramide, and she was on Bupropion. The doctors completely missed the interaction, and several reputable sources also missed the interaction. And this kind of begs the question as to how many other things are there out there in the literature among drug information sources which are also incorrect or inaccurate, and how many patients have been harmed, or maybe they didn't receive any kind of benefit from a treatment because of something that was missed, because we rely too heavily on 1 or 2 sources when there's plenty of evidence out there. It's kind of like the iceberg. You see the tip of the iceberg sticking up out of the water and the whole thing underwater. How many patients did not receive adequate care because we drew assumptions or we overlooked something? That is the question. Good luck in your research.